the Global Child Dental Fund and the World Federation of Public Health Associations All Health Group series on the role of silver diamine fluoride and dental care. We're going to focus particularly on the COVID-19 pandemic, present situation, and then obviously post-pandemic, the different activities. I'm Professor Raman Bedi, Emeritus Professor at King's College London and Chair of the Global Child Dental Fund and the World Federation of Public Health Associations All Health Group. In the first series, I interviewed Dr. Ali Attia, the CEO of a chain of pediatric dental clinics in New York, and Professor Pandit Pantum Vanit, who is the chair of the National Oral Health Strategy in Thailand and the former dean of Thammasat University in Thailand. They discussed how SDF is being used in the United States and in Thailand, and particularly in urgent dental care. In the second series, I interviewed Professor Richard Needleman, who's the director of the World Health Organization Collaborating Center at the School of Dentistry, New York University. And he discussed his view how SDF would be used in the new world and how it would shape dentistry for years to come. Today, I'm pleased to have on our panel 4 leading experts to consider the role of SDF could play in the United Kingdom, and particularly during and post COVID-19 pandemic. We have Professor Nicola Innes, who is a Professor of Pediatric Dentistry at the School of Dentistry, University of Dundee. Professor Paul Ashley, who is Head of Pediatric Dentistry at the Eastman Dental Hospital, University College London. Dr. Andrew Osaso, who is the ambassador for, or an ambassador for Mouth Cancer Foundation and is a special advisor to the CQC in the United Kingdom. And of course, the internationally renowned Dr. Linda Greenwald, who is a leading dentist here in London and specializing in cosmetic and restorative dentistry. It's important to say that this webinar series receives no funding from any dental company, and that all the speakers, none of the speakers receive any funding from a commercial corporate. So let me set the scene. At present in the United Kingdom, we are in lockdown. There is no routine dentistry and all patients are sent and triaged in a particular way that manage their dental problems, basically around the 3 A's, giving advice, antimicrobials, and analgesics when appropriate. When a patient needs to be seen by a dentist, they have to do so in a face-to-face situation, then this is undertaken in designated urgent dental care centers. These centers are trained staff, strict protocols, and all staff have personal protection equipment. We agree with all that, and the discussion today is that the role SDF could play both today, when we're into the warm period, and potentially in the future of dentistry in the United Kingdom. Nicola, can I draw you into the discussion and ask you to just outline for us what is SDF and how does it actually work?
Hi, thank you, Raman. SDF is a clear colourless liquid that we can place on teeth, and it has a number of uses. It's been licensed in the UK, for, well, along with the rest of Europe, for a number of years now, but it's only recently begun to be really taken up by people. So its main purpose is to arrest active carious lesions, usually dentinal ones rather than ones that are in enamel, but it can also be used to prevent dental caries. There's pretty good evidence in quite a large number of randomized controlled trials that show that it works well on a population basis and on an individual patient basis. And we've been using it in our department at Dundee Dental Hospital and School now for, I think, probably nearly a year with a lot of success. So it's very good at, as I said, arresting carious lesions, and we tend to use it mostly in open dentinal lesions. The big disadvantage of it, of course, is that it discolours lesions, which is why we tend not to use it on enamel. We tend to use fluoride varnish for that. But for the open dentinal lesions, it functions really well in actually producing a hard surface from what was originally a soft surface and an active carious lesion. We've seen quite good results, in some cases even very dramatic results, to arrest caries. It works by 4 modes of action, really. It works firstly on the cariogenic bacteria by a number of different mechanisms acting on their DNA and different parts of the bacteria cell wall to kill them directly. And it also works by remineralizing because of the fluoride that's in it. It has an action on the dentinal tubules when you use it on dentine by blocking the open dentine tubules to some extent, which can help with sensitivity as well as helping us trying to arrest caries. And the last way it works is by inhibiting matrix metalloproteinases, which are things that are involved in collagen degradation. So that really gives us quite a good clue as to how it can work at that level. And I think it's worth saying that the main licensing in the UK is around it being a desensitizing agent, which I've already spoken about. But the function that we're most interested in is to try and get it to arrest these highly active lesions, especially in patients that are either pre-cooperative or have got multiple lesions that you just can't manage on a whole mouth basis all at once.
Oh.
How is it used? Well, it's very, very simple. It looks for all the world like water, and we use it by applying a microbrush. Because it can discolor skin as well as teeth, we do take quite a lot of care to make sure we've got good control over the oral environment. So we usually put Vaseline on the lips to start with and isolate the region. We then use the microbrush to dab on the dentinal lesion itself and on the tooth once we've cleared out any debris that's in the cavity. And we apply that just using the microbrush for around about a minute, agitating it around the surface, then dry it off with usually a cotton pellet, which again means that you don't have to have any involvement of the 3-in-1 or any aerosol generation at all. And that's really all that's involved with it. Of course, before you start doing that very simple procedure, the most important point is to actually make sure that the parent and child understand what's involved. So we have a patient information leaflet that we use that gives examples of discoloration, and we talk it through very carefully with the parent beforehand so they know what to expect and they are agreeable that this is the right kind of treatment for their child. Following placement of the actual substance, we sometimes find that some of the children notice a bitter taste, so occasionally we'll put a little dab of toothpaste on their tongue. There's some evidence that by putting fluoride varnish, by putting sodium fluoride varnish on the lesion afterwards, you can increase the remineralization potential, but the evidence for that isn't strong enough to really make a big deal out of it. I think the SDF seems to do most of the job on its own. We don't usually restore the teeth after we use SDF because we tend to use it as an alternative to other treatments, but there are some people who are placing crowns or glass ionomer straight on top of a lesion afterwards. Follow-up is really just about making sure that the lesion's arrested. So when we see our patients, we usually get them back 2 to 4 weeks later. And at that appointment, we'll run a ball-ended probe over the surface to try and just ensure that we've got that hardness. And if we haven't, we'll do another application and then just review them and try and put biannual applications on if we need to. But it's very simple, very straightforward, as long as you've got that control.
Thank you, Nicola. That's really helpful. So it's a very simple procedure, and really there's no need for any aerosol activity because it can easily be placed on a microbrush. Paul, can I turn to you? Because one of the things that we are hearing in our acute urgent dental centres is the children who are on the waiting list for general anaesthetic. What advice would you give to dentists who are facing that situation presently in the urgent dental centres, and then moving on then when we come out of the lockdown, but we're still reluctant to use aerosol relating activities? How could SDF be used for children?
So thank you, Raman, and thank you, Nicola. And yeah, if I talk about how we've used SDF on our own journey, because we've gone from being a centre treating children in the routine way to now being an urgent dental care centre. So we've had quite a big journey ourselves. So we started using SDF back in 2018, much in the same way that Nicola's been using it. But as of the COVID-19 crisis, we've had to close our GA list, we've had to stop routine care of children, and now we are what's called a hot hub. So we're seeing patients who are COVID-19 positive or suspected positive, and patients who aren't. So our immediate problem is that at the moment, as you said in your introductory statement, we can only really do the 3 A's. So I think they're all over SDF now. There probably isn't a role for SDF now, because any treatment we can provide is what's required to get a child out of pain. We have been using it opportunistically. So we have had children who've come in to say have a tooth out. And then if they've got some untreated caries, we've been putting SDF on that. But really that's been quite a structured approach. And I think where things will get interesting is when we move into what you've called the warm phase, where perhaps the lockdown restrictions are eased, and we can start to think about our patients who should have had a GA by now, or who are stuck on a GA waiting list. And we have ordered SDF in preparation for that phase, because I don't think we've thought through fully how it's going to work, but it's clear there's going to be a large number of children who conventionally would have had a GA and had teeth removed or restored, and now that's not going to be possible. I think we don't see GA coming back for a while, purely because the main hospital is stretched, having to manage patients with COVID-19. And we don't see AGPs coming back for a while, perhaps not until a vaccine is introduced. So I think our strategy with those sorts of patients, if we're talking to dentists who are managing patients who should have had a GA, who've got caries affecting all of their teeth, is really to push the use of SDF. I think in our own unit, we're imagining a combination of SDF for anterior teeth with Hall crowns in the posterior teeth. But we are a unit that's very used to and very experienced in placing Hall crowns. And I think a point you made before we started, Raman, is obviously Hall crowns have the disadvantage if they need a second visit. Clearly, that's something we're trying to avoid. So our internal discussions at the moment are really around maximising the use of SDF, using SDF in a way that we've not been used to using SDF, which is really to try and arrest all the caries that we see. Does that make sense?
Yes, it does. Can I just ask you to reflect on the current policy is to only treat the acute situation. So if a tooth is actually the cause of the pain, then just treat that. But in other countries, at the same time, to avoid a second visit, face-to-face visit, they're using SDF on any open cavities so that that doesn't create another problem in a few weeks' time. What would be your advice to dentists working presently in urgent dental centres if they're seeing children? Would you advise them to manage the situation that's causing the problem, but then to put SDF into any open cavities?
No, I think that's what we're doing, Raman. That would be sensible. Yeah,
Okay.
I mean, how much difference that will make on a population basis, I don't know, but I think if somebody comes in and you see untreated caries, why would you not place SDF? It's relatively straightforward, and you're saving yourself, hopefully, some problems down the line.
Okay. Paul, thank you very much. Andrew, if I could turn to you, you are very experienced in community, and there are communities that will have dental problems and find it difficult to attend a dental centre, dedicated dental centre, particularly in care homes, or in situations where they're housebound, or even if they're in prisons and under restraint. What advice would you give to dentists facing those situations?
Well, we know that dental caries is a huge problem, and it's a devastating disease that doesn't just affect the young. The level of dental decay is often highlighted, and we have been taught in dental school and other places like this to treat caries surgically. but there's a growing body of evidence showing that the pharmacological management of dental caries is successful. So for about 5 years now, I've been using Silver Diamine Fluoride effectively in the salaried services, but also in a general practice. And what I've been trying to do is encourage colleagues to think, speaking from experience, it takes a considerable time to refer patients to the salaried services, and during that time the decay can get worse. So could general practitioners do more to help patients? Particularly I've got experience in treating adults and those in vulnerable populations. And as Professor Innes said, the use of silver fluoride in dentistry is not new. It's been used to treat hypersensitivity. There's a growing body of evidence to show the efficacy of SDF. There's over 12 randomly controlled trials about its use. The latest one was by Professor Lynch in Nature. So really, we shouldn't be just thinking of this product or this agent just for children or the high needs. The way I practice my dentistry is how I'd like to treat my family or myself. Yeah. So it's a very, very effective tool. And one particular use that I like using SDF is, you referred to earlier on, as the silver modified ART technique, or the SMART technique, which I can briefly go over.
No, it's okay. Andrew, I was just thinking also about, what advice would you give to a dentist who has to go to a care home in this present situation where there is real challenges? How would you advise them to approach the type of dental care? Obviously dealing with the acute situation, but then where could SDF play in that scenario?
Well, we know that we have to do no harm, but we have a duty of care. If we see a patient in distress, part of our assessment, if we see that there is active decay, SDF does have a part to play. However, it's important that dentists recognize when it should be used. It's important to do a caries risk assessment, and also explain to patients, as Professor Innes said, about staining. But it's been shown to be very effective at arresting decay.
Good, thank you so much. Linda, general practices are finding this financially really very difficult period with this lockdown. But if we have a prolonged aerosol-free dentistry, what do you think the challenges are going to be to the dentist, and also what part could SDF play in a prolonged aerosol-free dental care scenario?
Dental practices are having major problems at the moment being shut, and major financial problems with the equipment, having to put it on a special cycle to maintain it, but to protect it. And so there are many issues. The reason I was late, we had a staff meeting on Zoom to discuss all these issues in terms of maintaining our practices and continuing to support our patients via telephone triage, and dealing with things like temporary crowns coming out and those minor emergencies, but still important for patients. So I think going forward, going through the challenges, SDF is very useful, that can be applied in an aerosol-free environment as simply as possible. And patients would appreciate that they are treated as for an emergency that can help in a simple way going forward. It's a simple technique and can be used very effectively. We've used it a lot in outreach in our programs with the children in South Africa. And it's quite amazing how quickly you can see it working. Even in front of your eyes, you can see caries, for example, crystallizing right in front of your eyes. It's quite amazing. So going forward with the challenges, as soon as the warm phase is announced, we will be able to use that for many patients in many emergency situations, simply without generating aerosols.
Sure, thank you. Nicola and Paul, you're both in teaching situations. do you think we need to teach our dentists, or do you think this is such a simple technique that they'll pick it up straight away? Do you feel that there needs to be a period of retraining of dentists with regard to aerosol-free dentistry? Nicola, hi.
Hi. I think that need often drives, or necessity is the mother of invention, and I think it's such a straightforward procedure that most general practitioners who are very used to handling the oral environment need much less training than we already give our undergraduates. So the paper that we published in the BDG had a step-by-step guide to placing SDF, and I have absolutely no doubt that that will be perfectly adequate for most GDPs. And it also involves some case selection, although I think that case selection is perhaps what we need to look at, especially as Andrew says, with regard to elderly people and people who've got limited access to dentistry or who need additional help. So we maybe need to expand that a little bit more for the warm phase and make it specific, which is something that we're working on at the moment as a group around the UK, trying to get something together with that.
I mean, just to add to Nicola's comments, I'm already talking about this at Section 63 type meetings. I know dentists they're not interested in how to place it. They can see that. Their interest is how do they actually get hold of it. So I don't think teaching or training is really the issue at all.
There needs to also be a national discussion about payment. How will dentists under the National Health System be paid to do that? Obviously, Nicola, you work in Scotland with a fee for item, and Paul in England under a band system. There's quite a lot of discussion of payment systems, and because dentists will want to know how they are going to be remunerated in an aerosol-free environment. So that's going to be a very interesting national policy decisions that need to be made. Linda, have you got any reflection about the cost to the dental practices with a prolonged period of just doing aerosol-free dentistry?
So the major cost implications for all dental practices and all dentistry going forward, first of all, with the impact of extra barrier protection and the way going forward we will be working. We will not go back to our previous way of working. We will always be working with visors, hats, masks, the FFP3 masks, if we can get them, full barrier protection, basically surgical appearance. The cost of operation goes up, and in addition, we will be looking at screening our patients and testing them with the finger prick test once we've had the studies, and once we've got the test, we will test all our patients prior to working, and all that adds to the cost of operation. So in terms of private practice, that will be passed on to the patient. The patients would, at the moment, the patients, what we are doing is calling our elderly and vulnerable patients and checking on them, and they're delighted to receive calls from us because nobody calls them at all during the day. But going forwards, patients will understand, and they will accept that because the option is no dentistry during this time. So they're quite appreciative of it.
It is, and I think this is an opportunity for the whole profession with regard to NHS dentistry to rethink, because the costs are going to go up, to rethink what can be offered, how it can be offered, and how dentists are going to be remunerated. I think that's a national debate, and I hope that just won't happen in small sections, because I think the whole profession needs to discuss this of how we are going to use this learning that we've learnt about dentistry and the challenges, and to how we shape the future. Andrew, I don't know if you've got any reflections, because I see an opportunity to re-emphasize prevention, and particularly roles of SDF and non-invasive types of activity within NHS dentistry and private dentistry.
Definitely, there is a growing body of evidence, and those in the salaried services have definitely taken to SDF based on the evidence. But again, as Professor Ashley said, many dentists are not aware of SDF or how to get it. So it's important as key opinion leaders to let fellow colleagues know about this product and the efficacy of it. And I'm always encouraging colleagues to look at the evidence themselves. And then once you can see the effectiveness of it, money is out the side, because we do the best for our patients.
Good. Well, we've come to our 30 minutes, and which is the time that we allocated for this webinar. So thank you all for your contributions. I think one of the things I hope for out of the pandemic is that we started a new type of debate about what the new world will look like. And I do hope that we don't fall into a scenario of business as usual, even if a vaccine is found and we go back to normal. That we can start to rethink of how we provide dentistry, the focus of prevention, and all the different tools that we have. And today we just looked at one aspect of it, which is Silver Diamine Fluoride. So Nicola, Paul, Linda, Andrew, thank you so much for your contributions. This is only the beginning of a debate, and but you've started it really well. So thank you very much.
Thank you.
Thank you.
Thank you.